Okay, everybody, I'm Tarek Rashid. I'm affiliated with Washington College, but I'm not actually estranged from Amrita University. I've been a part of the family, Amrita family for several years here. And every time I come here, I'm thrilled with the innovation, the compassion, and the new great idea that the community here, Amrita, is pursuing, especially my dear friend and inspiration, Dr. Bhavani Rao, and the amazing work she's doing on the front of gender and technology, and even the very basic idea of having this conference is in itself is a very innovative idea. So applaud to Dr. Bhavani because she is my inspiration here. I'm glad to welcome you all for this kind of phenomenal, session. We have amazing, extraordinary speakers who each one is going to exploring. By the way, this is not ChatGPT prepared. It's prepared with another AI called Notion. Just kidding. So our first speaker is Dr. Carol Gregorio. Her keynote title is Breaking the Heart Code, Gender Difference in Cardiac Health. Dr. Gregorio is Professor of Medicine, Senior Associate Dean for Basic Science and Founding Director of the Center of Cardiac Muscle Biology and Mount Sinai in New York City. Her cutting edge research has revealed that female and male heart muscle cells differ significantly at the subcellular level, providing new avenue for detecting, preventing, and treating heart disease in women. She will discuss how combining biochemical, cellular, I hope I'm not spoiling your talk, biochemical, cellular, and geometric data with AI may reshape care for women heart. Let's give a warm welcome for Dr. Carol.
It is really fun for me to be here today. Thank you for this opportunity. So the topic I'm going to be talking about is breaking the heart code, gender differences in cardiac health. And one of the reasons I'm going to be talking about this, I'm going to do it more from the medical perspective, but I'm hoping those of you who build devices, who do AI, could think about the issues I'm going to discuss. And next slide, please. But why should we care about this? The reason we should care about this is cardiovascular disease is the leading cause of death. About 1/3 of the people die of cardiac complications. And heart disease, according to the American Heart Association, is the #1 killer of women. Next slide, please. I can't read it. Yeah. So I'm going to first start with some background about heart disease in women. First, women present with distinct symptoms, symptoms that are different, and their progression differs. So this often leads to an incorrect diagnosis. And traditionally, women are not part of clinical trials. They have different outcomes, so it doesn't sort of fit in what people are looking for outcomes, so they're excluded. It's worse than that, though. Even in preclinical studies where we have, let's say we're working on mice, usually the female mice are excluded or the female and male mice are grouped together, so it's impossible to see if there's any sex differences. Exclusion of women of this type leads to development of therapeutics that are often less effective in women because they're focused more on men. And sometimes they even have different side effects in women. And women are, interesting enough, are considered sort of cardioprotected earlier in life. They have less heart disease earlier in life. This could be linked to hormones, of course. But yet when women have heart disease younger, they have worse outcomes. Next slide, please. So this is really also, I think, pretty interesting. The basic morphology of a heart differs in male and female. Women's hearts are smaller, they have thinner walls, but what's even more apparent over the last few years, based on having single-cell analysis now, is that the composition, the cell type in the heart of women is different than in men. Women have more cardiomyocytes, more mesenchymal cells, and less endothelial cells. And this leads to different physiology of the heart, where their heart rates are usually increased, their blood volume is increased, they have lower systolic and diastolic pressure. And it's also interesting, in exercise, women's hearts tend to get larger proportionally than men's hearts. Next slide, please. Women also have different biological risk factors. And some of this is related to hormone differences. Women have pregnancy-associated cardiovascular disease. This could be very bad in a lot of women. Postmenopausal cardiovascular disease is prevalent. Women tend to have spontaneous coronary artery dissections, which men don't, their counterparts. They have more HFpEF and microcirculation dysfunction. So what is the biological basis for it? Well, it turns out the more we dig, the more biological differences we find that are obviously very linked to having different prevalence of different heart disease. There's variations in the hormones, which I've mentioned before. The coronary arteries morphology are different between male and females. That leads to different hemodynamic patterns. Fibrosis is different, inflammation is different, and as I mentioned before, the cell composition is different. So this all contributes to various progression of heart disease. Next slide, please. When we think about men presenting with heart disease, it's often this crushing feeling in the heart. Well, women present differently. They often have pain in their shoulder, their back, their neck, their jaw. They have shortness of breath. They have nauseous. They're nauseous. They vomit. They have clammy skin, and their severity of the symptoms are often different. And sometimes they're tolerated, or women dismiss the symptoms, so they may not seek medical care as quickly as they should. There's also symptom timing. Often women realize that they have had symptoms for over a month, and it was something that just gradually occurred, which often prevents them from getting the care they need. And then there's also really well-used diagnostic tests like cardiac catheterization, which are very, very effective, but may not be as effective in women because women are more likely to have plaque buildup in the smaller arteries. So what I'm trying to establish here is that the hearts of women are very different in men and women. Next slide. So I've told you at the whole body level, at the organ level, at the cellular level, women are different with their respect to their hearts. Well, it turns out they're also remarkably different at the subcellular level, which is something that, again, is a very new field, active research, and it's probably very much linked to why women present differently. Even something like excitation coupling is when the body triggers the stimulus to cause contraction of the heart. That's different. Also, the dynamics of the protein turnover, which I'll show you on the next slide. Continue, please. Continue, please. Okay, so this is what my focus of my research is the structure of the heart. And, okay. Could you go back? No. Go ahead. Go ahead. No, please go forward. One of my slides was completely screwed up. Forward, please. Forward. Forward, please. Okay, next slide. Okay, so what it's supposed to show on top is a beautiful electron micrograph of individual contractile units. But what you could see on the bottom is a model for contractile units. And how muscle is built is that each of these contractile units are next to each other, and together they cause contraction. Well, these proteins turn over a lot, and that is different in females that I'll show you on the next slide. So this is an experiment where someone in my lab who actually did the dual degree program with Amrita and the University of Arizona, who's in my lab now at Mount Sinai, performed. And what we do is we label proteins with a fluorescent dye, we bleach them, and then we look at the recovery. And that tells us really quantitatively about the turnover of muscle proteins. And as you can see on the bottom, the red is a female, male is black, and you could see the dynamics at the subcellular level of how proteins turn over in muscle is different. Next slide, please. So for the theme of today, now I'm going to switch a little bit to the progress that we made in detection and prevention using devices together with AI. So there are these wearable devices that many of us wear. They are incredibly effective for smartwatches and portable monitors to detect atrial fibrillation and ventricular dysfunction. They give us real-time ECGs to monitor and enhance detection. Then there's innovative screening tools, which is really cool. They have these stethoscopes now that are much more sensitive than the typical ones that physicians use to hear heart murmurs. They are guided by AI, they're much more sensitive, and they detect valve issues much more apparently. Then there's also mammography. If we have a radiologist who is looking at a mammogram, can look at the arterial, they can calcifications. They can also frequently detect heart disease in women. Then there's continuous remote data collection that we know all about wearables that could track stress, physiological activity, disease progression. Then there's remote monitoring, which telehealth, for example, that manage chronic conditions like hypertension and heart failure. And it also could track medication adherence. Next slide, please. There's also a lot of other important benefits of devices and AI. The inclusion of diverse populations. The devices facilitate participation of underrepresented groups in research and in real-time assessment of remote care for underserved populations. We also have real-time risk assessments that lead to personalized interventions. And this could provide continuous tracking to predict cardiovascular risks. And importantly for this meeting, it could integrate gender-specific factors, for example, pregnancy outcomes, to allow for accurate clinical decision-making. Next slide. I'm going to give you some examples here of some that's gender-specific, what could be managed by apps and devices. We talk about wearables. These ECG monitoring enhances early detection and monitoring during pregnancy. Then there's portable diagnostic tools. For example, portable ECGs and AI-supported tools that manage conditions like pregnancy-related cardiomyopathy. And also they can monitor recovery post-pregnancy. Next slide. So summary is that women are often excluded from preclinical and clinical trials. We've got to change this, and it is happening, at least in the NIH, at the National Institute of Health in the United States. We are required to have this as part of our grants now. The hearts of women are different, from the whole body to the cell to the subcellular level, and this is probably very indicative of how their heart disease is different. Women present, as I said, with different symptoms, and devices and AI can significantly increase effective care for women. And it's just very important for women to pay attention to their bodies and seek medical care if something doesn't seem right. Next slide. So the future directions, I believe this is my last slide, is we need to increase integration of digital health tools for improved diagnosis and monitoring based on gender risk factors. We have to continue to invest in AI to combine physiological, biochemical, cellular data, genomic data to identify pattern markers and biomarkers that are specific for women so they get the care they need. We need to improve precision medicine to close the research gap. This is really important, to accelerate understanding of gender differences and develop gender-specific therapies in heart disease. Next slide. So I just want to thank you. This was an incredible opportunity for me.